who is Marissa Naherney, and she's going to be speaking on evaluating HIV vertical transmission patterns stratified by infant feeding practices and referral location at 2 Ugandan health centers. So for our very first session this morning, we have a bit of a Uganda theme and healthcare in Uganda. To give you a little bit of background on Marissa, she's a third-year medical student here at the University of Alberta, and she's been passionate about global health for a while. Her and I have worked together on a few projects, and I know about her great interest and her passion in this field. Marissa graduated with an honors Bachelor of Science in Health and Society from the University of Calgary in 2018. Her keen interest in maternal health led her to conduct several research projects and an honors thesis evaluating obstetrical and neonatal health outcomes and improvements in Canada and internationally. She aimed to marry her interest in tropical medicine, equity, and maternal health through participation in a field school in rural Tanzania, where she studied gendered perspectives on water and sanitation issues. She went on to intern in Mbarara, Uganda, through the Queen Elizabeth Golden Jubilee Scholarship, developing community-level initiatives to improve maternal health with Healthy Child Uganda. And Healthy Child Uganda, for those of you who don't know, is a great program that was started by the Canadian Pediatric Society, the CPS. In 2019, Marissa was named the ASTMH Ben Keane Fellow, allowing her to return to Uganda and continue pursuing her research interests regarding infectious disease and global health. So at this point, I'd like to invite Marissa to present. Thank you.
Thank you for the introduction. My name is Marissa. My project today is going to be looking at my evaluation of HIV vertical transmission patterns stratified by infant feeding practices and antiretroviral therapy at 2 Ugandan health centers. So beginning with an overview of what the burden of HIV is through vertical transmission in this area. So 6.1% of pregnant moms in Uganda have HIV. And among those not taking any medications, no antiretroviral therapy, vertical transmission rates, so any transmission from mom to baby, is between 15 to 45%. 50% of this vertical transmission is through breastfeeding exclusively. However, once we introduce antiretroviral therapy, that vertical transmission rate drops to less than 2%. In terms of acquiring antiretroviral therapy, 72% of those who need it, mom-wise, have it, and then 37% of their babies have received any form of prophylaxis. So with this slide, for the purposes of this presentation, it's important to recognize how therapeutic and prophylactic regimens have changed over time based on our study sample, since our study was looking from 2008 to 2017. My intent, however, is not to get caught up in the details, but to provide a general understanding to treating women with HIV. So option A was introduced in 2008 and was by far the most complicated antiretroviral therapy regimen of them all, with changes throughout the antenatal period. So we can see that right here with the prophylaxis. Changes from antepartum to intrapartum to postpartum. And this was quite difficult for moms to acquire the right drugs and for them to be able to access timely management of their HIV. This medication, nevirapine, was given to babies, but for differing lengths based on their breast milk exposure. As I was mentioning, the strategy was shown to be difficult for implementation. However, if we move on to options B and B+, as those were rolled out through time, we kind of streamlined. We saw some streamlining where all women with a specific CD4 count were receiving triple ART regimen. So really a lot easier to harmonize strategies across higher burden countries. And as we moved on to option B+, it was quite unanimous across the board what moms were receiving. So current breastfeeding regimens, if we're looking at moms who have HIV, in low to middle income settings, breastfeeding is recommended for the first 12 months, with exclusive breastfeeding for the first 6 months. And the reason why this is different, so if you were in Canada and you had HIV, a doctor would tell you do not breastfeed. Like, let's exclusively feed the baby formula. And the reason why it's different here is because there's disproportionate access to safe drinking water and appropriate sanitation. So there's a bigger risk posed for infant diarrhea and malnutrition in low middle income settings, as opposed to the risk that breastfeeding with an HIV positive woman imposes. So what my study looked at was associations between feeding patterns, ART regimens, and vertical HIV transmission among Ugandan infants born to women infected with HIV. So methods for my study, we conducted a retrospective observational study using clinical records from 2009 to 2016 at 2 publicly funded hospitals in Uganda. So one in Jinja and one in Kambuga, both in the southern part of Uganda. These hospitals were unique in that they had early infant diagnosis clinics. So HIV positive women were referred here during their postnatal period for further testing and follow-up, as well as evaluation and treatment of their infants. So for methods, using records for up to 10 postnatal visits. So it was kind of nice and longitudinal in that aspect. You have a mom and then catchment for her is following up over 10 visits, ideally. We created variables for infant age at weaning, age at last breast milk exposure. And these records also contained a lot of information about the final known outcome of infants, as well as their age at registration of the clinic. So at what point were they followed up? Were they lost to follow-up? Did baby end up getting HIV? Those types of details. We then moved to descriptive statistics, looking at infant weaning, ART adherence or procurement, as well as PCR results for infants. We concluded by doing some risk reduction calculations and then Kaplan-Meier curves to follow outcomes over time. So in terms of our sample, we started with 1,885 infants, and we can see through time what the PCR results were as well as retention. We can see that the largest loss to follow-up was right after the first PCR. So 60% of this 88.5, 60% of this 11.5. So this was a large area of concern for loss to follow-up. However, we can also see that the majority of infants were negative after their first PCR and then subsequently after their second PCR. So there was 2 PCRs done for infants to determine their HIV status, one at 6 weeks and then following up ideally after weaning. What we can see here, however, is potential breastfeeding transmission. So infants had an initial negative PCR, ideally 6 weeks after. However, exposure to breast milk was the only other change for them. And then a second PCR perhaps demonstrates some concern there. In terms of retention and care, so this Kaplan-Meier type figure can show us the outcome of each infant with the records available. So in this figure, all patients were accounted for at some point in time. So everybody started out in this remaining in care. So that meant that we didn't necessarily have an HIV status for them. They were breastfeeding and they were retained within the sample. So starting with loss to follow-up, this is this light gray color. We can see that this was an extremely common outcome in our sample. And generally infants were lost to follow-up at a consistent time over their ages. But what's important to note here is this HIV uninfected or confirmed component, so this white portion. It's very slim. So this means that infants had a negative PCR after weaning, so their exposure to HIV was in fact over and they still did not mount an infection. This is what the goal is across the board. And if we were to look at a higher income country, so even in Canada, this would be the majority of infants. So this is our goal for low to middle income countries as well. So the significance of this graph is in the fact that the ideal outcome was still only experienced by a few, and infants remain in care here. So we can see over time that we did have an outcome for them, but even trailing off over here, we still don't know about some of these infants. So results based on ART cohort. So not getting caught up in the numbers again, but I definitely wanted to show some trends. So what we decided to do is stratify our outcomes, so mortality, vertical transmission, and confirmed HIV-free survival by the different options. So this is the age at which infants were born. And what we can see here is some trends. So mortality based on regimen had gone down over time, as did vertical transmission. And confirmed HIV-free survival did increase over time. And what we can see here is this risk reduction was calculated with option B+ as our reference category, and the asterisks demonstrate statistical significance. So these were important results to go over. When we stratified by feeding practices, we didn't really see a particular trend and there were no statistically significant results. However, that doesn't necessarily mean that there isn't some importance here, because what we then did is this Kaplan-Meier graph. So this is where we were looking at the proportion of infants breastfeeding over time according to their year of birth. So as we had kind of discussed earlier, the year of birth is related to the implementation of new ART regimens. And what we can see is with the more recent strategies, retention to breastfeeding, I'll say, was maintained. So more moms were breastfeeding over time and for longer periods of time. So weaning was definitely closer to that 12-month age rather than a drop-off in this period of time. So limitations. Of course, there are some concerns here with potential changes over time in PCR quality. So were we actually identifying the right infants with the right outcomes, given the fact that collecting PCR results and then sending them for testing can be logistically difficult in this setting. And then we also had, as demonstrated, a significant loss to follow-up in our sample. So some concerns there with what was going on with those infants. Were they more vulnerable for vertical transmission? Were there areas that we could have identified for intervention? However, what is important to recognize is that our sample is rich in other information, particularly breastfeeding data, as feeding method and age of weaning were discussed at each clinic appointment and followed over time. So despite this loss to follow-up, these data are from a real-life high-endemicity setting, demonstrating the extent to which these issues are experienced in real time. So to conclude, this study did show some clear patterns in infant outcome by year of birth and therefore their likely ART regimen, and longitudinal information on infant feeding. So our further directions as directed by this data is identifying strategies for retention, as I was discussing, especially after that initial PCR where we saw a lot of loss to follow-up. So was there a logistical concern? Were moms from rural areas, et cetera, as well as identifying associations in subsequent data between loss to follow-up and transmission. So in those infants who were lost to follow-up, were they more likely to have some form of breastfeeding transmission later on that we weren't able to identify in our records? Thank you for listening. I'm now open to questions and I appreciate the opportunity.